What you're going through doesn't compare to the glory within. If you are to suffer, then you are to reign with Him. What can separate me from the love of Jesus? Nothing separates me from Him. And we have a promise that says all things. For the good who love Him, all things, everything, works for the good of them, and you are. What you're going through, doesn't compare to the glory within. If we are to suffer, then we are to reign with Him. What can separate me from the love of Nothing Jesus. Separates me. Nothing separates me from What can separate me? Jesus, nothing separates me from Him. And we have this promise. All things, everything, God works for the good. Yes, we love Him. Many of us have probably heard this song before. Let the poor say I am rich, let the weak say I am strong. But I always wondered, when will we actually be strong? When will I actually be rich? And I realized that I could go to God's word, and like God can speak some things into existence that aren't as though they were. So it's time to speak some things into your existence. It's time to speak prosperity. It's time to speak happiness. It's time to prophesy victory. Help me sing this. I've got victory. I shall prosper. No longer shall I be bound. God has made me free. I've got victory. I shall prosper. No longer shall I be bound. God has made me free. Come on, let's take it up. Said I've got victory. I shall prosper. No longer shall I be bound. God has made me free. Good evening, and thank you all. Thank you everyone who's tuned in for this much needed conversation. In case you don't know who I am, my name is J.T. Harrison II. I am the lead pastor of the Collide Church in Strongsville, Ohio. Started a church during the pandemic. Who does that? I don't know. Me. I did it, but we're here. A big special thanks and welcome to my dear friends, my second church home in Wilmington, North Carolina. Freedom's Way is in the house tonight. So thank you all for being part of this. And my good friend and brother Bishop Garnett, thank you for having your members be here. So we're looking forward to take care of your questions, to answer them to the best of our ability. Real quick, why are we here? As I've said before, this might be your first time watching this conversation or seeing me engage this in any form. Why are we here? COVID-19, that's why we're here. We have prayed, the saints prayed, the saints prophesied, the saints spoke in tongues. And I don't say that disparagingly, but what do you do when the answer was no? We believed all 2020 that COVID would just go away, right? It didn't. It's still here. And not only that, it's adversely affecting our communities. I'm in a teaching series right now called Navigating Next After No. What happens when you're trying to move forward in life, move forward in something, and the answer seemingly is no? I think of the people from Thessalonica who, like the Apostle Paul, thought Christ's return was imminent. They thought he was coming like in a few days. So what did they do in hopes of it? They stopped going to work. They stopped doing their daily activities, and they just prepared for the return of Christ. But then people started to die, and time went on, and bills became due, and the people are wondering, well, what's going on? Paul, you said he was coming back really soon, but he's not here yet. And then Paul has to speak to that and address it. The passage we know most famously, well, here's what happens. The dead in Christ shall rise first. He's providing comfort in a space where it seems like God has said no. So we thought he was a healer, and he still is. We thought he was stronger, and he still is. But he hasn't quite dealt with COVID-19 yet the way we thought and or hoped and or prayed that he would. So now what? Now what do we do? This brings us to our conversation, because I want our people, I want you, Freedom's Way, Collide Church, anyone who's watching, I want us to make decisions not based on speculation, not based on rumor or conspiracy theory, but make your decision about how you govern this pandemic, how you govern the vaccine, based on the most accurate data you can have. So we invite you and welcome you tonight to bring your question. This is a question and answer series, town hall forum. So bring your questions, bring the tough questions. We're not running from any questions. We're not running. We ain't scared. All right. So bring all your questions. I'm excited to introduce our panel. So I'll bring them back real quick and we'll get right to it and get your questions rolling even right now. First, we're bringing to the stage my friend Alexandria Rosa. She's a registered nurse with an ICU background, clinical instructor. She does everything. She's a teacher. She's working on her doctorate right now, and she's here to help us and give us perspective on what it's like to be inside the hospital. So, Alex, it's good to have you. Thank you for being here.
Thank you so much for having me back again.
Next, coming to the stage, my good friend, longtime Baldwin Wallace alumni, Brother Gene Baker. He is Regional Account Director of the U.S. Market Access in Michigan and Indiana. He's from the pharmaceutical company. So you got a question along that, hit him. He knows. And we're going to be honest with you and tell you what we know and or what we may not know. Mm-hmm. Last but not least, another Baldwin Wallace University alumni, Yellow Jackets for Life, my friend and sister, Shanina Knighton. She does it all. She's a KL2 scholar and faculty at Case Western Reserve University. She is a clinical nurse scientist and infection preventionist. So if there's anyone we should talk to on tonight, it is this wonderful woman right here. I'm so glad to have you. Thank you. Thank you.
Thank you for having me. And I would actually say that about the other esteemed panelists as well, in terms of our backgrounds and our different perspectives. So thank you, JT, for putting this together.
It is my honor. So I'm looking to see if we have any questions yet. I don't know if I see any yet, but what we can do is go right here. Let's talk about the skepticism of this vaccine. I've come across so many people who said it was made too quickly. It got here too quickly.
Um, there wasn't enough people tested it on, right? Right. Let's speak to that to get the ball rolling as we wait for the questions to begin pouring in. Thank you.
Mm.
Yeah, I
Who
guess
wants-
I'll start us off there. First to say, that is a very
Not
reasonable
here.
question, right? And it's a very reasonable concern. And I think it's really important to understand kind of the history that went into very briefly, the science behind the vaccines. Also understand that we say vaccine. There are a number of vaccines out there, and with different technologies behind them. There are two vaccines that use the messenger RNA technology, and I'll speak to those because I think it tells a different story. That technology, that science, started back in like 1990. Professor out of University of Pennsylvania, and really the idea behind it was, hey, if we can send a message to our cells to make other cells, what are the possibilities behind that? You could then program your cells to make any number of things, any number of cells, including embryonic cells. And if you can make embryonic cells, you can cure all kinds of paralysis and all kinds of things. So the science behind it, once it got going, was like, whoa, what are the possibilities? But in the beginning, it was this idea that didn't get a lot of funding. And then over the years, different scientists came on board, the science improved, they made some progresses. And so they've been studying this, I guess is the point, without getting too much into details, since early 90s. And then that's come all the way through the 2000s, all the way up to today. So companies have formed, the science has gotten a lot bigger, better. You've gotten a lot of research. I mean, billions of dollars has gone into these companies for research. So you look at that. So that's been happening. Studying across a number of different things, from cancer to other disease states, not just viruses. And then you look at what happens with the coronavirus. We say, well, how did all of a sudden we get this vaccine? Well, we didn't just all of a sudden learn about coronavirus. I'm sure many of you have heard that there's been coronavirus out there. So yes, there's been coronavirus out there, which means that scientists are very familiar with the family, the genus of coronavirus. Now, this particular subspecies of it was new, right? But they knew enough about the family to be way ahead of the game. Next, you had to think about, okay, we got this pandemic, and why didn't they make this vaccine before? Well, money. It takes a lot, millions of dollars to fund research, and so a lot of companies didn't want to do it. A lot of universities didn't want it. Government didn't want to fund it until you had a pandemic. Oh, all of a sudden, everybody wants to fund it. So all this funds from the government, from all these different private sources came into play to say, okay, yeah, we want to fund this thing. So then the companies that were involved in it started to put the money into it to research. So the structure, the scientific structure was already there, so that wasn't just overnight. The knowledge base of the coronavirus family was there. They just needed a little bit more to understand this particular variant of the coronavirus. And then the global community came in and shared a lot of insights to help, even further speed that along. And then you had patients, which is another big part of this. Typically, to get through all the different phases of clinical trials, you need patients, you need a lot of funding. And any one of those steps could be a roadblock. All of a sudden, you had all the funding and then all these patients that were able to be enrolled to really spur these clinical trials on. And so with that, then you had these clinical trials that were very open, right? In terms of the data that was being shared. So the transparency of these clinical trials was critical in order for people to accept or trust the results. So I'll stop there, but the overall arching of that is, hey, this science was a long time ago coming, and everything kind of just came together at the right moment with the global community and the factors behind these scientific inventions.
So Gene, I'm gonna add on to that because, like, I'll be honest, towards the end, you know, somebody might think you sounding like a conspiracy theorist, like, of, oh, well, how did it just come along kind of thing. And I think, you know, it's important for people to understand that science may not necessarily be on our radar all the time. Coronavirus has been around since the 70s. Even though this pandemic is the first time that everything is shut down as greatly as it has, it's not our first go around with pathogens, okay, and with germs that can potentially harm us. And so many times when people are hearing, well, they already had the vaccine ready, or this seemed like it was already in the makings, and this is all a setup, we have to also remember that when the last SARS was around, when the Middle Eastern virus was around, those are forms of coronavirus. And so they were around previously, and so it just didn't show up, and treatment doesn't just show up. And so I always have to make sure that I mention that, because many think that that is the case, unfortunately. And then too, just piggybacking off of what you said, Gene, with the funding mechanisms, before it would be pharma having to go to the government and saying, this is what I have. This time it was the government going to pharma and saying, this is what we're going to put our research dollars behind, which are our taxpayer dollars. We need to start coming up with some solutions so that way we can try to tame this issue.
Yeah, that's a huge thing. Because I was doing a lot of research, just understanding that, you know, the amount of funding needed is massive. So the fact that the government was able to kind of spur that and back that, along with private backers, really enabled this research. And it's not just these two companies. There's many companies around the world that are studying, you know, vaccination. So huge point.
Mm-hmm.
We have our first question from Hosea Anderson. What do we know thus far, Baptist, early I know, about the length of the immunity once the second vaccine is taken?
I'll jump in. Well, in my point of view, or my opinion on that is, to be 100% honest, like, we don't really know, to be honest, because there's just not enough time. Like, we haven't been able to track this, right, for enough time to know what the long-term effects of the vaccine are going to be, and how our immune systems are going to hold up, and how it's going to be reactive to all of these mutations that are going on. And so, in 100% transparency, we do not know. But what we do know is that if we can get more people vaccinated, and we can cut down on the transmission rate with people washing their hands and social distancing and wearing their masks, the less likely we are to have more mutations and having to deal with all these other external things that are going to be pushing back our timeline with what we already have going on with this emergent situation we have right now, which we don't need all these other mutations, right, adding on top of it. We just need to get vaccinated, you can, and wear your mask, social distance, and just keep doing those things for right now to slow the spread down. Because honestly, we don't know what how long this is going to last. And as far as tracking reactions to the vaccine so far, you know, the CDC has their own app and website that you can go to, and they're keeping track of information. They want you to report it if you're having a legit reaction to it or having some effects from the vaccination. They really don't want you just to go on Facebook and complain about it. Like, we need to track these things in a healthcare type situation, in a setting. So, you know, if you're really having reactions or concerns, you need to check out reliable scientific websites and resources to get your information and to report. And as far as I saw another question about why do we need to get a second vaccination? Why only one and done? And it's like a lot of our other vaccines, right? We have to get boosters every so often because our immune system kind of drops after a while. So you do need to get that second dose. So you get with a lot of the ones that are out right now, you have to get your first dose, which introduces your body and gets those antibodies start to work. And then you need to get that second dose to really make sure that your body's going to keep producing those antibodies. So it's just important to stay up to date with those, just like all of our regular booster shots and immunizations that we get. Same thing with this.
So the other piece of it that I want to add on to, with the question about immunity, I think realistically we all have to think about the timeline here of when COVID-19 was first announced. And like, let's be realistic, like the cases in Seattle or in Washington, the state of Washington, was around the end of February. And then actually it was the second week of February, because you had the first death that occurred, which was on February 29th of 2020. So then when you look back at when we actually started to administer the vaccines itself, and I'm not talking about administering the vaccines, I'm actually talking about going through trials. Even with the individuals that was in trials, you know, it measured efficacy. So did the vaccine work? Did it produce antibodies? But we have to understand here that we're still about a year and a little bit of change from the time that some of these, actually it's less than that. Like we're still, like I'm talking about maybe like 8 months, if anything, from the time that a trial started. And so many are expecting this vaccine to have like the same, they're expecting, I would say, information like we have on chickenpox, where we know the chickenpox vaccine is going to work and it's going to protect you for X amount of years. And truthfully, we just don't have that information right now. It is promising in terms of like, you know, there are certain vaccines, which are Pfizer, the BioNTech, and the Moderna, which is said to protect for up to 2 to 3 years. But we honestly don't know if this vaccine is going to be something that's going to be annual like the flu shot. Somebody mentioned too, as Alex was mentioning about the doses, like, you know, why 2 doses? There are other vaccine candidates that are starting to surface, such as Johnson & Johnson, you know, who's saying that there may be a potential of a 1-dose vaccine opposed to 2. But just as she mentioned, our body does need boosters. And so it is very well that we can be looking up at a situation of where the COVID vaccine needs to be given annually. When it comes to the strains itself, nothing stays the same. We don't stay the same. So after this conversation, we're going to be forever changed. After, you know, when we walk outside and we get different experiences, we're going to change. So this virus is not going to stand stagnant and just decide that, you know, we're not going to mutate strains. The difference is, though, and what they're finding is that it is mutating less than the flu. So flu has a greater variation than what we're finding of these strains of COVID-19. So it's not showing that these vaccines should not have some sort of effect towards these additional strains. But to the case in point, the goal is to try to slow it down. And vaccines are a method of trying to slow down the spread as well as herd immunity. So it is a method to try to slow it down.
The fewer people that this virus infects, the less chance it has to figure out how to mutate.
Mm-hmm. Yep.
I want to go back to something quickly earlier, then I'm going to throw another question out there. Because I like to put things in layman's terms, right? So the funding piece for the research to get a vaccine, right? Let's think about that a little practically, right? Let's say you are a carpenter and something happened worldwide that calling all carpenters to come and work on wood. You want to get paid, right?
Yeah.
You're not going to price gouge in the midst of a global carpentry pandemic. But it's rather absurd to assume that you would just render your expertise and services in life for free for the next 2 years to better the world. So when we think of funding, we got to think of like, you know, that's in the lab somewhere. That lab needs oil, gas, heat. It needs light. It needs someone to open. It needs security guards. Keep them safe. And the people that work there. So you think, you know, funding, I don't want it to get lost in a rabbit trail of like, oh, they're trying to get paid. Well, that's precisely it. Everyone wants to get paid. People who's researching it, people who's giving out their time. But that's that. We have a question right here.
Jay.
Yes, sir.
When we think of funding, I think people are thinking And in many cases, rightfully so. Well, pharma is they're going to get a big windfall out of this. And it's not a simple answer. Vaccines in general can often be what they call a loss leader. It's a tricky science, just in terms of, okay, you're making something that will be a one-time dose, twice, maybe boosters. It's not something like a medication that people will take every month, where you're going to have steady, profit. So you got to consider that one thing. Two, some of these companies like AstraZeneca and others have said, you know what, during the pandemic, we don't want to, we'll charge at cost. Okay. And then once we get through the pandemic, any other, profit that they potentially make, they'll work that out. Other companies are charging at cost and then a little bit more. So it kind of depends on the company. It depends on what they have. Some of these companies, they don't have anything. They've never even, like Moderna, they don't have a product to the market yet. So they need this capital. So they're not going to say, hey, we'll just make this at cost. No, they need this capital to pay for all the things that they've done up to this point and then moving forward. So there's, versus another company like a Pfizer or J&J or Sanofi, whatever, that make vaccines all the time and make other products. They have, a bigger base of a portfolio to rely on. And then you got to think of, okay, as we vaccinate, and this is the other part of the loss leader, some companies, the richer companies, they're going to pay more. But when you vaccinate for something that's can be a pandemic, a global pandemic, you got to get that vaccine across the world to stamp out this virus. Well, there's a lot of countries that can't afford it. So when you think about manufacturing a vaccine, you got to think about supplying that vaccine across the world. So the richer companies will pay for more of it, but you got to get that out across everywhere. So all these things that go into a company, setting a price for a vaccination. But during this initial pandemic, it seems of the companies are saying, okay, we're going to take this at cost. We're going to work together to get this vaccination out to stamp down this pandemic.
But I think that's the thing that's, and this it has to do with science, but it doesn't. And I honestly think it comes down to how we function in our own lives. Meaning, yes, while I would like to be altruistic and give everything for free, I still have to live, and all of us do. And I think that right now, like some of the questions, that are posed when it comes to like the financial situation of things, at the end of the day, these are still the same pharmaceutical companies that have been making blood pressure medicines, that have been making diabetes medications, all kinds of things for chronic conditions. And it is very interesting to me that, yes, while there is concern over this particular vaccine, those medications are often not questioned. Like individuals take them because they know that they're going to need them in order to be able to get better from some sort of chronic condition. And so I think the cost thing, the fact that we are at a point in time of where people are being given, a vaccine and saying like, hey, there is no charge for it. I find it's like the boy that cried wolf. So it's almost like you've charged me for my medications all of this time, and then now here it is, they're free. And so the skepticism that people have, it is greatly understandable. But it can also be the boy that cried wolf on the other side, and that this could actually be a solution that works. But here it is, you don't take it because of the skepticism and you end up suffering. And so that is why it's important for the information to be shared in a transparent manner, to understand that, no, we're not looking at a perfect solution, but there are some individuals that have chronic conditions and situations that honestly, it's like if COVID gets a hold of them, they're almost on the verge. It's like a ticking time bomb, or their risk is higher, in verge of having complications and death because of their comorbid conditions, and working along with COVID, So I think that's something that people should also think about is, am I healthy enough to not take it? And I think when we're talking about health, what goes into that equation? And to be honest with you, we've seen the statistics even before COVID has come up. We know that we're overweight. We know that the majority of Americans have multiple chronic conditions. We have a lot of things that just honestly don't make us as healthy as other countries. There's food ingredients that are banned in other countries that are not banned here, and that are also contributing. I'm not going to say that can be contributing, but are also contributing to our problems. And so I really think that as we're investigating, let's say, ingredients and ways of trying to say maybe this isn't a good fit for me, is we really have to think about what are we doing for ourselves and hold ourselves accountable, for our own health, and not just thinking about this vaccine as being that mighty moment of where we want to be accountable and in charge of our health.
Thank you for that. So I'm excited to announce, guys, we had a special guest here. I met Dr. Deborah Farrell Holden a couple of weeks ago. We were on live. She was doing her thing. I was all in. I was leading the charge with questions. We connected afterwards, and I said, "Sis, if you could please come on and be another voice." And she's here, and I'm just like, oh my goodness. She is the Associate Dean for Public Health, Integration and Director of the Flint Center for Health Equity Solutions, funded by the National Institute on Minority Health and Health Disparities. Major person in the room. I mean, we're all major. We just got majorer, right? So this is Dr. Deborah Farrell. Thank you for being here. Thank you.
Thanks. I'm going to catch up just by listening. I'm going to catch up on the conversation. I just ended another talk, so I wouldn't resist the chance to join. I really appreciate the work that everybody's doing to be trusted, credible messengers in this season. So,
yeah.
Thank you. We're going to get to it. We got another question.
Well, can I tack on to the last comments, just in terms of our own health? I was speaking to someone the other day about COVID and what was going on, and what should we be worried about? And I said, well, one thing you got to understand as well is, as African Americans, just in Michigan, we're about 15% of the population, but we're 40% of the so if you're worried about some conspiracy to stamp out the African American community, what's going on right now? And then, so it's almost like our community got hit by an earthquake, and the tsunami is about to come. Because now you got an even more virulent or easily transmittable, virus on the horizon and being spread. That's going to very easily spread through our communities. So what we're doing today, and really helping people understand, and you in the audience, please understand all the facts behind this, because our communities are already being devastated. And if we don't get a stamp on this and really slow this down in our communities, this is going to be even worse.
And JC, I think we addressed the question that's up there already, about the news and the different strains, and just the fact that, yeah.
Here we go. We're catching up now.
Yeah, I think we alluded to this one too.
Right, we just touched it, honestly. Well, sis, Audrey White, if you feel we answered your question, if we did not, hit us back. We'll do it again. We'll keep moving. This one comes from Torianne Hart. Has a vaccine ever been produced this quickly? I'm finding that this is the real place of contention for most. We kind of touched on this, but let's touch it again.
Can we hit that last question? Just, there's a part of that I think that we might be missing. Because I have heard this in the community, where people that have or immune disorders, they're concerned about, should I take a vaccine? So can we address that a little bit? Are there certain populations that should have specific conversations with their clinician, with their doctor, or that should not take a vaccine?
So I got a question, Dean, before we even get into that, since we have Dr. Farrell-Holden on the line. I personally would like your perspective about something that I find is interesting. So the CDC and the World Health Organization both take a different stand on both the Moderna and Pfizer vaccine being safe for pregnant women. And so I'm finding that a lot of individuals that come to me, some of them may be following the CDC, which of course is United States driven, where we have others that are following the World Health Organization standards, which are saying it's not safe for pregnant women. And so I know for me, my thing is if there's something that is saying no, even if CDC is saying yes, I'm still telling individuals or patients that I may interact with that as of right now, I don't think it's safe for pregnant women, because I'll be honest, ethically, I would feel bad not knowing that it hasn't really been tested on that population, giving the ethics around the sensitivity of it being a vulnerable population. So what are your thoughts on that?
So I'm always going to lean to what the best science tells us, and I want to be really clear. I'm a PhD level epidemiologist. If I was a medical doctor, I would not give medical advice to somebody who wasn't my patient. And any credible medical doctor will not give medical advice to people that they're not treating and that they don't know and have under their care. What we can give is good medical information. This is a timely question for me because I just found out about a month ago that I'm going to be a grandmother. I have a 23. I know, right? I have a 23-year-old daughter who is just finishing her first trimester of pregnancy. So we're literally dealing with this issue at a place that hits so close to home for me. Mm-hmm. My baby, my firstborn, is about to have a baby. So I got a lot of dog in the fight on, is this thing safe for pregnant women, and getting good information. Yeah. So what I know is this. The trusted source for obstetrics and gynecology is the American College of Gynecology, organization called ACOG. My Aunt Vicky used to work for ACOG in DC, so I used to hang out there with her on Saturdays. She worked every other Saturday, and I used to hang out in the ACOG office and read the pamphlets. ACOG has said it is safe for pregnant and lactating women, and that they recommend that when women who are pregnant or lactating, when their priority group comes up, that they be offered the opportunity to get the vaccine. Okay, so that's what that's
Pfizer? Do they speak to Pfizer or Moderna, understanding that like their trials might have been a little bit different in their population? So the participants that participated might have been different. Like, do they speak to that? Because I'm even finding too that there are women that would actually like to see what that looks like. So they don't even, it's like they want to see the science, but they also want to see the trials.
Yeah. And so I'm giving you my Dr. Deborah Verhoeven answer, and then I'm gonna give you the Grandma Debbie, real human being making decisions on the ground floor answer. So what we've requested is that ACOG do a review of the clinical trials data in pregnant women. We've got lots of specialty populations, especially that affect African Americans. I work very closely with the president of the National Medical Association, which is the Association for Black Doctors, oldest, longest standing organization of Black doctors, representing the collective voice of about 60,000 physicians in the country, African American physicians. So ACOG says it's okay when their number comes up, they should be offered. That wasn't quite enough for me. I haven't seen the clinical trials data specifically as it relates to pregnant women. So now we're faced with the decision in our own family. It wasn't enough. It wasn't compelling enough for me. And do I trust ACOG and their recommendations? Of course. They're giving the best recommendation that they can based on the data that they have and what they know. I don't believe they're in some conspiracy to euthanize pregnant women or whatever. So I believe that. As a family, we made the decision, and my daughter made the decision. She was working as a patient advocate in a hospital at the time. When she found out she was pregnant, she was offered the chance to take the vaccine. She opted not to take it, and she resigned the position because she decided she didn't want to work in a healthcare facility where she had excess risk to COVID. We as a family decided that we weren't comfortable, because if in 2 or 3 years we find out, in fact, there was some side effect, we don't want to learn that lesson at the expense of this soon to be new addition to our family. So the decision that we made was that all of us would get vaccinated, and we would continue to honor the protocols to build a hedge of protection around her. So my other two kids are both in college. They both have been offered because their number has come up. I am connected to a healthcare system. So I came up in category 1A. I've had my first dose. I get my second dose on February 11th. And her two younger siblings are both getting vaccinated on next week, this coming week. So, if I trust the CDC, if I trust what ACOG says, it doesn't matter Pfizer or Moderna. They're saying it's safe for pregnant women. We personally did the soul searching and decided that if this was 2 years after we had 50, 100,000 pregnant women vaccinated, and we were confident that there would be no long-term implication for her or her unborn fetus, maybe she would get the vaccine. But in the absence of that, we've made the choice as a family to build a hedge of protection around her by us all getting vaccinated and continuing to honor the protocols and prevent her from contracting it in the first place. So that's the Dr. Deborah Verhoeven answer. And then that's the legit family member, well-informed, dealing with and having had to have made the decision.
That's great.
Thank you for that.
Yeah.
So let's throw the next one up here. Has a vaccine ever been produced this quickly? I'm finding that this is a real place of contention for most.
And the answer to that is no. It hasn't been produced this quickly, but also we're in a very unique situation. And then, as I spoke to before, there's a number of factors that came into play that enabled this to happen. So, how this happened was very unique. So I don't think we can apply what happened before to today. There's a lot of things that happened from the research that happened starting early 90s to a pandemic, to funding from the government and private and everybody funding this thing. There's a lot of things that happened to our knowledge of the coronavirus versus some unknown, totally, unknown virus, So a lot of things came into play all at once that really, enabled this to happen. So it was nearly a miracle that it would happen like this. But if you piece everything together, you can explain and understand that, okay, well, that makes sense. A number of things lined up and happened all at once. And here we are today, with a vaccine.
Can I say something else about that, though? Because there is one critical piece of this that's a little bit different, which is that mRNA vaccines specifically, messenger RNA vaccines specifically, have been under development for 2 decades. Yeah. You can produce an mRNA vaccine, a candidate, in 1 to 2 weeks. Once you have the genetic code for the virus that you're building the vaccine for, you can actually build a candidate vaccine within 1 to 2 weeks. Now, the process of the actual clinical trial was accelerated, but no steps were skipped. If I'm just going with the data that is, available from the FDA, with the Data Safety and Monitoring Board, who has to sign off on this before it could get its emergency use authorization, no step was skipped. But because we are in a pandemic, we move through the phases much faster. The only thing that we're losing, not that it was skipped, but the only thing that we're losing is if you were to test the vaccine for phase 3 on 50,000 people, that would be happening typically over the course of about 2 years. Well, in this case, it happened over the course of several months. So if there is some unexpected longer term impact, we are only going to be finding out about. Time will be the only way for us to tell that. But people should know that now that mRNA vaccines, they were already on the cusp of being a new standard. And now that standard has been utilized for the development of COVID vaccines, we're going to see a lot of candidate vaccines for different viruses come to market a lot quicker than we've ever seen in the past. Because once you get the genetic code to make a candidate vaccine, it's like you've got the code, you just put it on the genetic photocopier and you can make a candidate vaccine. So this is going to be the new norm for us.
Yeah.
I think, to put it in somewhat of layman's terms, as we talk about messenger ribonucleic acid medical flex, as we talk about messenger RNA, the best way I understood it, you all correct me if I'm wrong, it was as if, and you want to know I love to travel. That's my love language. I go to Europe, Sweden every year, except for 2020, of course. But they say, JT, send me your passport. We need your passport. Now, I don't deliver my passport in person to the people in Germany or Sweden or France. I don't do that. No, what I do is I take a picture of it, a photo scan, I email it to them, and from that scan, they get all the information about me that they need. Similarly, the way this mRNA works is they don't put the virus in you, they just scan it and email it to your body, speaking metaphorically. So it's not the virus actually being put inside of you, but just a picture of it to give your body all the information it needs about it.
Mm-hmm.
Well, particularly for this virus, what was critical was to isolate the protein that makes the kind of the key that enables the virus to connect and enter a human cell. So once they figured out that protein, then, as Doc was saying, you know, you put that into the system, into your computer system, and you can then make the messenger to then go into the human body. So, you know, it's fascinating stuff, really. But you're right. You know, once you figure out what you're trying to replicate, put that into the system, and then make your vaccine. And then, you know, part of the issue was, as they were, you know, working with this technology, was not just coming up with the messenger, right? The blueprint for the human cell. It was, how do you protect that message, you know, for the human body not to break it down before it gets into the cell and tells the cell what to make. So that took a long time to figure that out.
And that's the difference in the two storage systems. One is wrapped in a big fat bubble that, if left out too long, it's unstable. So to keep it stable, it has to be stored at this really, really cold temperature. And if it's thawed out, it will become unstable. And then the thing that we're getting injected in, it's like it's the ride, right? If you got to get somewhere and it's far, you got to go through a whole lot of rigmarole to get there, you'd rather be in a nice big SUV. It's the SUV that carries the virus to the spike protein to the cell. And if you can't get it there, if the car breaks down, well, then you're just stuck in the car in the middle of nowhere. And that is what would happen to the vaccine that you get injected with if it wasn't properly stored. The ride that it needs to get to the cell would break down, and the thing that you need would never make it to where it needs to go. And eventually your body would just clear it, treat it like trash and clear it.
Yeah.
And then too, just really quick, I just want to remind people that it's not the same technology, but the H1N1 vaccine had to undergo rapid production, you know, during that time because of what it is that it was doing. So it might not be the same exact process in terms of us getting it out as rapidly. I understand too, like insurance back then, money, you know, the factors of money. So a lot of things were different. But that was still something that once that arrived as being a pandemic, that there was still a mass development and a mass production of it to be able to get it out to individuals, even if it isn't the same technology. And so I just want to say that, because I know that there's this, oh, well, we haven't had a vaccine developed this fast. Maybe not with the mRNA, but we have done this process in the past. And it was just about 10 or 11 years ago, you know, when we were facing the H1N1 pandemic.
We have another question. Should we now be wearing 2 masks as suggested by some TV stations? Doubling up.
I could answer this. I wouldn't take advice on my daughter's delivery from my auto mechanic. So just because the news station said it, I don't. There's doing the most, and then there's doing the least. So people that are walking around without a mask on are doing the least, and the people that are walking around with 2-3 masks on, N95, 2 filters in it, they're doing the most. And I don't know if you've ever had even your mask on for a long period of time. I have such empathy for people that work in the big box stores and physicians. I inhaled my own breath for about an hour in a big box store, and I was over me. I'm like, I would never kiss me if this is what I had to kiss. So I give people the very basic, the match test. The match test. Mm-hmm. You put your mask on, you light a match and you hold it 6 inches in front of your face. If you can blow that match out, you've got too much air coming through and potentially too much air coming in that the mask might not be a sufficient layer of protection. If you cannot blow the match out 6 inches in front of you, your mask is fine. We don't need to do the most. We don't need to do the least. If we encourage people to do the most, all we're going to do is mess up compliance. It's going to be too much for people to adhere to, or it's going to be too cumbersome. So I really encourage people. It's simple. It's fun. Everybody in the family, put your mask on and do a family round of the match test. You'll even find a bandana, if you double it over, will pass the match test. A bandana, if you have it single layered, will not.
Right.
So that's my recommendation.
Right, and I'm just gonna add on to that, but it's more so from the infection prevention piece, because that is my expertise, and it does matter depending on the number of layers that you have on. But I always bring this up: if you are not handling your mask correctly, meaning washing your hands before, cleaning your hands afterwards, being conscious of the things that come in contact with your mask, where you're sitting them down at, then you may attribute getting COVID-19 to having on too many layers or not enough layers, but it very well can just come down to you not wearing it correctly or not handling it correctly. And so I oftentimes bring that up as well. There are recommendations in regards to the materials that your mask should be made of, if they are cloth. I know, like they say, like the kitchen towel material, you know, is one of the best that are out there to be able to filter out, or, you know, any kind of droplets. So there are a lot of different ones that are out there. I would just also caution individuals as well to make sure that they don't have such thick materials to where you are self-suffocating. And so that is where the dangers of this come to me at, of where, you know, it is being recommended 2-3 layers at a time, because I've seen individuals and it's like, how are you breathing through that? And I know that it's not breathable material. And so it comes a fine balance of what's safe versus what's not. Like, I know a lot of healthcare facilities, even ones that I'm doing research at, we actually offer everyone a surgical mask because we can't guarantee if someone's cloth mask is going to be safe enough or not safe. So.
Yeah.
Wow, this is so good information. I want to let everyone know you can still bring your questions. I'm going to pause real quick to do this. We have a couple of giveaways we want to do. And not going to take a lot of time to do this because I want to honor the time of our panel. But we have here, it says size large glide shirt t-shirts. This goes to the person who is tuning in from the farthest. So we want to know who's tuning in. We're in Cleveland, Ohio. So let's base it on Cleveland. So who's the farthest from Cleveland, Ohio? All right. Second one we want to do, we have a Pan-African colored shirt by Hush and Do. That's my line in my book, Shameless Plug. And since Black History Month begins tomorrow, what I want to know, whoever can first answer, Dr. George Washington Carver made a piece studying this plant and all the juices. What plant is that? Please let us know in the comments. And whoever wants a Black Lives Matter shirt, you can have it. Just let me know. All right, back to COVID. AJ said he's on the east side. No, it's so farther than that, for sure. I always want to ask this question and bring this light to the room. Alex, you being a registered nurse and being in the ICU, what are you seeing? Because people always say, and we do this question a lot, but it's a 99% recovery rate, right? But what are you seeing in the rooms? And I know Dr. Knight, and you can speak to this as well. I mean, everyone can. What are you seeing that you want to push back on people who don't take it as seriously because the majority recover?
I think saying recover is different for everybody. Everybody considers recovery different. And I think to a lot of people, recovery just looks like you get sick for a week or a couple days, and then the next day you're right back at it, going to work, you're 100% or back to where you were. And the reality is, for most people that I have been in contact with and that I know personally and have seen at work, it does not happen like that at all. The long-term effects in the recovery process. I mean, I feel like so many people are still recovering, like people that have just gone back to be 100% or where they were before. It's not there. There's just so many lingering effects, if it's like a respiratory breathing, or if it's brain fogginess, or if it's like the lethargy, and you just can't get yourself back to where you were before. And a lot of it is a lot of emotional issues that people are having. And even sometimes I think there's like a stigma associated with saying, oh, I've got COVID, or, you know, I tested positive, and people are afraid to admit that or want to go get a test and are kind of living in a denial type bubble and are doing more harm to others. And it's real. I've seen so many patients in the hospital that they're relatively young, they're late 20s and 30s, and they're on ventilators and they're on dialysis, and that's not the norm. And it's not the norm to have 5 or 6 patients in an ICU that are all intubated, that today's the day that we've decided they're not going to get better and we're going to take their breathing tube out and they're all going to die in the same day within hours of each other. Like, that's not the reality. That's not the norm of what happens in an ICU, but that's becoming the norm now because of COVID. And it's up just to all of us, like we've been saying this whole time and how we said last time, it's up to all of us. We have to do what we know we need to do. We need to wear a mask, we need to socially distance, we need to try to get our vaccine if we can, and to protect others. Just like Dr. Holden was saying, we have to protect others around us if they're not able to. We have to look out all for each other. And it's very serious, and it's serious on the patients, and it's serious for the healthcare workers, and the emotional stress and the stress that you already have from your family that you're bringing into the hospital, right? Because even though we're all healthcare workers, we're all still moms, dads, grandmas, grandpas. We are normal people, and we have our own life situations, and then we're having to deal with that, and then deal with all the emotions of doing our work of care, right? Of caring for others that are there in the hospital. And it's very emotionally draining, and that's a whole nother subset of issues and lingering effects that are happening because of this pandemic.
And Alex, you bring it up so greatly, because I actually have experienced that personally and have even had that with friends, you know, that are nurses, to where we work in healthcare, taking care of other people, you know, during this time. And the minute that your loved ones get sick, you can't even go in and be with them and can't even take care of them. And you know how strained the healthcare system is right now. And I think that's been like the message that I've been trying to articulate to so many, is that it's, oh, well, why we got these lockdowns and why we have to do this. And it's such selfishness. But many really don't realize, like, it's over 330 million people in the United States, and our healthcare system has a total of about 1 million beds, and we don't have that many ICU beds. And so we're talking about a place of where we already have individuals with cancer. There's the surgical population. I can go on and on and on about how many chronic conditions and the capacity that those beds were already filled prior to COVID. So then you add COVID on top of that, and you say to yourself, whether it's COVID related or not, can you get the adequate care that you need if you all are straining the healthcare system? And I think that is the message that I'm constantly trying to preach to others, when it's, oh, well, why we got to do this and why we got to do that. And it's just this collective thing of, if you need the healthcare system, can you adequately get the care that you need? You know, it's like you want people to think about you in which the way that you would want them to think about you if you needed to get care. And I think that is the thing that is often missing, is we forget that our system is strained. We're forgetting that these are human beings, as Alex alluded to, are taking care of other people. And I'm telling you, it has been so stressful and just painful to just watch care being given, or, you know, knowing that here it is, you need to be there with your loved ones. And so that is what I want to stress to people, is that when you're thinking about this vaccine, and Dr. Fur Holden mentioned it when she said we ended up getting vaccinated to protect her, because this is what we know. This is what we don't know right now, when it's a decision that we made for our family, is individuals thinking about who depends on me. So who depends on you, and who do you depend on, and how does that change, your viewpoint as to whether or not you should get vaccinated. Like, you have to weigh if the risk is bigger than the reward or vice versa, but not just for yourself and for your health, but it's for those that are around you. Because there are a lot of individuals, and when we talk about minority communities, we have like those multi-generational households. So it's the small kids that's living there that's, you know, potentially can go back to school and transfer at home. And maybe mom, middle age, can make it, but maybe grandma or grandpa that live there won't. And so how do you protect your family unit? Because it's not just about you as an individual. And I think that is what we need to think about collectively.
Dr. Knighton, can I just add something to that? And I done looked you up. You a bad sister. And I love the nurses, because y'all know that is the real front line. So I just appreciate you for all of your work.
And likewise.
As an epidemiologist, I'll tell you, people often say things like, I'm going to just wait for herd immunity. And it kind of breaks my heart a little bit, because people got the concept of herd immunity a little off. And I fully understand where that comes from. But I want to just say a couple of comments related to what you said. The idea and the goal of herd immunity is not that people develop immunity through infection. That's not the goal, because that's not the goal of public health. And you can't get to herd immunity by having some significant proportion of the population, it varies by disease, who has immunity. And you get immunity either through vaccination or through natural infection and recovery. Notice I said and recovery, because what happens to the people who don't recover and they die, well, then our denominator changes. And that is not the goal. Public health's goal is to not have people die. The goal with herd immunity is to prevent people from getting sick in the first place. That's number one. Number two, because there's so many people who will not even be eligible, infants, toddlers, depending on which vaccine we're talking about, people who are under 16 or under 18, people with certain immune disorders or certain illnesses, there will be a number of people who will not be eligible. So I go back to my thoughts about my own daughter. We chose to get vaccinated to build that wall of protection around her. So for people who are eligible, and I don't tell people to take the vaccine. What I tell people to do is do the work, operate from fact, not fiction, do the soul searching, make sure you've got good information and access to good information ongoingly. And we can talk at another time about what different sources are, because I don't think there's any single source for this. Again, I'm not going to ask my great mechanic for advice on my daughter's pregnancy. I want the best OBGYN that Flint, Michigan has to offer, for that. She's actually in Baltimore, and we've got the best OBGYN, a sister who's phenomenal, taking care of her. So I want people to make sure that they do that and operate from fact and not fiction, because for all of those who are not eligible, it will be the actions and activities of those of us who are to build that wall of protection for them. Now you start to locate your.
Nope. Did we lose her?
Oh Lord, we lost her.
You lost it.
Oh Lord. Okay.
So until she comes back in, JT, because I was gonna say, like, there you go.
That's that bad Wi-Fi. Sorry about that.
Right.
Y'all got the point. Y'all got the point.
Yeah, and you finished off because I was listening to you. You said until we. You said
I don't know. I was being brilliant. Okay. I don't know when I left. I just know I got kicked out. The point is this: for those who are not eligible, for those who don't even have the opportunity because of age, because of health status, or other factors, the actions and the wall of protection that those who are eligible can build around them is going to keep them protected and also help us to turn the tides for the community at large. So I just ask people to consider that. To thine own self be true, but also factor that into that decision-making process. You will provide protection for your pregnant daughter, or for your little sister, or to your niece, or to your nephew, or to your uncle who has, HIV or something else where he might not be eligible, or somebody who's actively going through chemotherapy. There are things that you can do that are not just protecting you, but also protecting those around you and your community.
And just really quick too, because I think this, it's interesting, because I know we're having these conversations, but you brought it up, and it's the fact that everyone won't be eligible and everybody won't have access. And so even conversations, as well as, you know, things that are coming up now, is a conversation around equity. And so there are certain areas right now that even though minorities are at higher risk, they're not even being offered the vaccine, you know, whereas we're facing these same issues, you know, back in the day with the HIV/AIDS pandemic, you know, of just having access, you know, to care and other things that we need. And I'm bringing that up to say that we don't talk about the fact that we're not just looking at 2021, like making it through 2021. This thing may still be getting distributed into 2022. We're still not addressing the fact that there are individuals who don't have transportation, who may not have resources, that want to get vaccinated, but will know that they can get to that first dose, but may not be able to get to that second. There's individuals,
which will be a catastrophe, by the way.
Exactly. And
if
it
you
is
don't
already
get that second dose in the right time window, it's the effectiveness goes all the way down, and you basically would have to start over.
It's zero.
And I'll be honest. So as an instructor, I'm a clinical instructor, and so that's what my students are doing this semester. So we're working with the city of Cleveland to administer vaccines. And so that is my number one concern that I have right now, is as you're giving, because we're actually moving into the 1B group right now. So before it was like the 80 and up. And so just to think that literally when you're talking to these individuals and your mind as a nurse is saying, how can I get this man here, you know, within that 21 to 28 day window to be able to get this vaccine, get this second dose. And so I just want to bring that up to individuals, because oftentimes we don't check our privilege. So we may talk about what we're getting, we may talk about what we ain't getting because we have the power of choice. But there are individuals that don't have a choice but to take the vaccine, and there are individuals that don't have access to the vaccine. And so I just encourage us to think about what those barriers are. And instead of thinking about what it is we have access to and the ability of choice, how can we provide that choice as well as access to others? And I think that that's something, you know, that many people tend to ignore. And so if we think about that from that perspective, and we alluded to it even within our circles of our family, who is around you in terms of your neighbors that you know that they can't get to where they need to get to, you know, get down to go get the vaccine. So I have a 93-year-old neighbor next door. Are you going to go get vaccinated? If so, how are you going to get there transportation wise? I need to check on you when you get it. So make sure you call me so I can make sure you don't have any symptoms, you know, or anything that I need to check on you about. And so I just encourage everyone that, yes, even if right now you're saying to yourself, like, I'm not getting ready to do it, when it becomes eligible for my kids, they're not going to do it. Think about those that actually do want it, and how can you help to protect them? Because that's the thing. We are in a situation right now, and Alex said this at the beginning. We don't know potentially what the long-term effects are. We just know the damage that it's doing right now. So if we know the damage that it's doing right now, how can we start to mitigate some of that damage? And so if sometimes you can't be that voice to say, I'm going to go get it, and you be an advocate for it, then the best thing is to just, what they say, if you ain't got nothing good to say, then don't say nothing at all. I know that that's what my parents used to say. I oftentimes am conscious about what it is I'm saying, because I realize that decision, whether I am qualified or not, carries a lot of weight for an individual that may not have any access to healthcare, that don't know the difference between a PhD and an MD. So I just encourage us to just kind of think about that. And I'm not just talking about the panel, but I'm talking about, you know, even our listeners today, as we're thinking about our decisions and what we're going to make in regards to taking it and encouraging others around us.
Yeah,
that's so good. And it makes me think of a bit of, and then we'll wrap up, because we're at past 6 now. A bit of social responsibility, right? Now, what I'm going to say, this is not to condemn church or anything, but again, this whole premise of we prayed and we fasted and we believed and we COVID out blow on you, and he's still here. And so, in the faith perspective, I've always wondered, oh God, if God says seemingly no to something else, it's because more than likely he wants to promote something else. So the point that Dr. Knighton made about her next door neighbor is 93 years old. For years, I would leave my house here in Strongsville, Ohio, and drive 40 miles, 40 minutes, 45 minutes, even an hour sometimes, to go have church and share Jesus with people far away. Meanwhile, don't even know my next door neighbor's name,
Neighbor. Mm-hmm.
right? So what if part of this, or here's another example. You go to a church when we could, right? Parking lots are full of cars. But the fact that a church has a church van, what's the church van for? To go pick people up to church. There's a parking lot full of cars, but the church has to get a van. Why aren't we taking up the mantle of responsibility? Hey, I'm going to pick you up. I'm going to do this, right? And I know there's so many things that go into that. But what if, in the big picture, that maybe he said no to COVID because he wants us to get back to a place of where we lovingly care for another, as we aspire to in the New Testament church. That's what they did. What if he's pushing us to get back to the place of being selfless, to looking out for your neighbor, to leaving the corners of your field unharvested so that someone can eat? Huh? So I'm not just, I had to throw that in there because that kind of served my soul.
Yeah.
No, absolutely.
I would go ahead, Doug.
If you're gonna give us our 30 seconds to wrap up, I'll take my 30 seconds now, and I'll tell you a quick story. When my son was in the 8th grade, his grades had started to slip, and he said he wanted a game system and a TV in his room. And I said, well, you get straight A's and you can have the game system and TV in your room. And I went and I bought the flat screen and I bought the game system and I left it in the living room. Now, this is a kid that we had jokingly started calling C's and D's, because that's what his report card looked like prior to this semester. And I didn't sit down. I didn't spend more time with him. I didn't hire him a tutor. I didn't go tell his teachers what was going on. And that kid brought straight A's home. I still to this day don't know what he did. All I know is when what mattered to him, when I linked that to the outcome that I said I wanted and put the two together, he miraculously figured it out. This issue around equity, we often talk about and place all of that responsibility on ourselves, because social responsibility is not a trivial thing. The government should have mandated equity with COVID testing. They should have told the states your doses will be hinged upon making sure it's distributed and administered, i.e. put in the arms of people fairly and equitably. And all these issues around transportation and all of the barriers people face, if states did not hit the equity marker and as a result they got less doses, just like my son, I bet you they would have figured it out. We missed the mark from a policy perspective. And that is the push and the demand that we are making now on the Biden-Harris administration to mandate equity. If you can't figure it out, you don't get the doses, period. Because if this is going to further inequity, further privilege, further marginalize people who are already marginalized, then it's going to happen across the board. And just Cleveland, Flint, Chicago, Atlanta, I guarantee you, they would all figure it out. But they don't have enough skin in the game yet. So that's what I'm pushing for, a mandate for equity. We won't tell the states how to do it. We'll just attach those doses to the thing to the outcome that we want.
Yeah. I think from my perspective, the reason why I'm even participating in things like this is I think that we do have a social responsibility. We every one of us has a responsibility to our family and our neighbors to support knowledge and then access to the vaccination. My purpose here is not to convince someone to get the vaccination. That is a very personal decision, and I don't know. I'm not a doctor. You need to discuss that if there's concerns with your physician. But I am around science all the time, and I do have some knowledge that I'm willing to share. And I think we each should be very careful about, everyone that's listening that will be listening, be careful about what you're putting online and what you're putting out there. I see all these headlines where somebody had a side effect or somebody died, and what we got to realize is people don't read the context of the article. Some people don't even read the article at all. They just see a headline, and then they say, see, yeah, that's why I'm not taking it. And then they tell their friends, hey, you can't take this because somebody died. You know, without understanding, did somebody die, or what was it related to the vaccine, or anything? Without any context, it's so damaging. And in my view, it's damaging to the point where if someone who doesn't know is making a decision on things they don't know enough to make a decision about, that decision could end up killing them. So it's really important that all of us take the time to understand the science, the history, all the things around this vaccination if you have concern about it before you convince someone to take it or not, or even talk about it. If you don't know anything, don't say anything, but still help your neighbor and your family get the vaccination. The science is there. Everything that's around this, that's come to this point, supports, in my view, us getting the vaccination, that the vaccination is safe and effective. Ultimately, it's a personal decision, but just please, 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 be careful of what you're putting out there.
Yeah, thank you. For me, I would say, kind of going off of what you were talking about with trust and what we kind of had started talking about last week too, with the mistrust in the healthcare system and with drugs and the vaccines and everything. And I think for myself, especially, and in the people that I touch with my message and with my teachings and stuff that I do, especially in the Latino community and the mistrust that our community has for healthcare and with all the misinformation, and then throwing on top of the language barrier that our community had. And where do Spanish speakers get valuable, credible, scientific information, and who does our community have to look up to that is Hispanic, that is Latino, that they feel like they can trust and they can relate to, and that they would take advice from. So that's one thing that I've been really pushing for in what I've been doing, and what I love to hear about is trying to build that trust and trying to show people. And I think that was kind of our big theme tonight, kind of too, in a way, was where are we going to go to, get that credible information, that scientific information, and how to turn all that noise off of all that other information that we have going on. Just like you were saying, Jean, those Facebook articles, and I saw this and I saw that, and that's what I believe now. And it's, we're all professionals. We've all gone to school. We're all educated. Like, we know, right? Like, how many years, thousands and thousands of hours have we spent studying this stuff, and that we know, and we're just trying to put the best information into the hands of these people who will take the time to listen to us, put a little trust in us, right? And to give them the best information that they can to make the best.
Wow.
So just really quick, and I just want to bring this up briefly because I know, and I'm so excited. So when I tell you, Dr. Holden, I'm going to be looking for information about this work that you all are doing on equity. And trust me, I'm telling you, if you have one of those cell phone calls, okay, with the powers to be, one of the things that continues to come up is there are individuals that want to get vaccinated, okay, and they want to get, of course, the Pfizer or Moderna, because those are the ones that are being offered in Ohio right now. So we don't have the option of just the one dose right now. I have seen individuals that have literally been threatened to be fired as a result of not getting the vaccines, and their employers have told them to take the vaccine, whereas they are still unsure about whether or not they want it. These individuals that are saying that they are unsure are in a situation where they might not have paid time off. So they don't have money in their sick leave banks. They don't have resources saved up. And so the thing is they are essential workers, want to take the vaccine so that way they can have a level of protection. But know that if they take the vaccine and they end up getting sick, even if it's just for a couple of days, they don't have the time off allotted by their employers. And so then they got to run the risk of losing their job by trying to take a vaccine. So the thing is, and I guess I'm bringing this up because I don't have an answer for it, but when she brings up equity, It goes back to our conversation of just making sure that we are aware that when somebody say, no, I'm not taking it, it may be a lot more complicated for them than just saying that they're not taking it. That may be beyond our understanding or what they're willing to share too.
I've been crying this out. The myth is that it's all about misinformation. That's a myth. I know because I've been talking to and surveying frontline workers. That is the majority case for many of them. Yes. And then the ones that did go, and most people, in my experience, are doing pretty good after the first dose. Some people after the second dose are having maybe a day, especially the same day, where they might have a headache or feel a little sluggish, you know, different symptoms that really is just your immune system sort of really getting activated, right? But not exactly the kind of symptoms that you want to have to plow through and take blood or see patients, or it's just, but employers are not bringing that and there's no mandate for it. So literally, I'm like, if they try to force frontline healthcare workers, we will be right on their heels before that gets enacted to force employers to guarantee PTO for people, like special COVID PTO. You can't mandate one without the other. You can't force people to get a vaccine and then force them to be sick on their feet because they did the right thing or did what they were mandated to do, and now they're working and providing care. You don't want somebody providing care who's sluggish and has a headache and a fever. That's crazy talk. But you're right. The myth is it's all misinformation. Some people have seen what happened and validly chose no or said no for now. And we need to respect and honor that too.
Wow. Well, this has been a wonderful night. I'm thinking maybe the next conversation we should start on equity and barriers, especially the language barrier as well. So having said that, la próxima conversación y vamos a hablar en español. Que habla español. No, I'm playing.
That was excelente though. Great job.
No, but we're going to have this conversation again. I want to thank all of our panel for joining us again, and we're all doing this out of the goodness of their heart because we want to see our people do well, right? From Urchin Sweden, we'll be sending you a shirt. She's doing all the way in from northern Sweden. I think it was Hosea Anderson that got the question right about George Washington Carver. It was the peanut. And my last question would be, I want someone to name me as we wrap up or send me the message, the African American doctor who was credited having the first open heart surgery. Let me know that, and we will send you this T-shirt. Again, thank you to everyone who tuned in again to the wonderful panel, Dr. Shanina, Dr. Holden, Dr. Alex, because you're about to be Dicky Baker, my man, and I'm, of course, yours truly, JT Harrison, the lead pastor of the Collide Church. We thank you so much. You all have a wonderful, wonderful evening, and we'll get back to you. We'll get on it really soon, all right?
Thank you.
All right, you have a good night.